Hello, everyone. We will wait for a few moments so that everybody can join in because we see a lot of people joining in. So we'll give it another 5, 6 minutes for everybody to log in and settle down. Mhm. Still few people joining us. So another few minutes, please. Thank you so much for your patience, everyone. All right. So I guess we have most of the people who have joined in, but we still have a few lined up. We are still waiting for a few. So we will just wait for a couple of minutes more and then get started. And yes, thank you everyone for your patience. Please grab your cup of morning coffee before we get started. All right. Thank you, everybody, for your patience. And I hope everybody's grabbed their cup of coffee and we will get started. Good morning and a very, very warm welcome to all. Uh, my name is Nancy Duggal. By now, pretty much everybody knows, and I am the Senior Vice President, Prospera Global. It is a pleasure to have you all with us, and thank you so much for joining us this morning. Before we get into the substance, a quick word on why we chose this particular topic. For years, the conversation around provider networks has been dominated by one number, that is, how many? How many hospitals, how many clinics, how many pharmacies? Network size became the headline, and in tender documents and renewal presentations, it very often still is. Bigger was assumed to be better. But for those of us who work with claims every day know rather a different story and a reality. A network of 2,000 providers where the member cannot get an appointment, where tariffs vary vividly from the same procedure, where direct billing breaks down at the counter is not a strong network. It is simply a long list. What actually makes a network strong is far less visible than its size. It comes down to four things. And those four things are what we are going to spend our one next hour on. The first is quality, clinical outcomes, appropriateness of care. The second is tariffs, not simply the lowest rate we can negotiate, but rates that are sustainable for the provider and predictable for the payer as well. The third is direct billing. This is where networks are genuinely tested. A member standing at the hospital reception at 10 in the night really care about our geographic coverage. They care whether the approval comes through. Direct billing is the moment where all the contracting, all the systems, all the coordination either holds or falls apart. And the fourth is, which ties the other three together, is member experience. Yes, this, of course, is the most important because ultimately it is the member who judges the network and they judge it on handful of moments. I mean, all of us, would do that. How quickly was the appointment arranged? Did the guarantee of payment reach the hospital in time? Was there a bill at the end that nobody explained or talked about? What we have learned at Prospera is working across markets and across home country treatment programs. It is that these four pillars cannot be optimized in isolation. Well, squeeze tariffs without regard to quality, and you inherit clinical risk. Build an excellent direct billing process on top of provider who are unhappy with their rates, and it will still break. The intelligence today lies in how we balance all this together. So, over the next hour, we will look at how payers, partners are approaching this differently, how to select and tier providers on more than just discount, how to structure tariffs that actually hold, how to make direct billing genuinely dependable. I mean, we all would want that, right? And how to measure member experience in a way that changes decisions rather than simply filling a dashboard today. All right. So before we begin, a quick few housekeeping tips that I would like to share. We will have a question and answer section after the whole session. Please feel free to put in your questions in the chat box or the question and answer round, and we shall address them at the end of the session, which is during the question and answer segment. So, with that, I will get started and I will hand over the stage to my colleague, Mr. Ankit Saklani. Thank you so much, and over to you, Ankit.
Ankit, you're on mute.
I'm so sorry. Yeah. Thank you, Nancy, and thank you for everybody letting me know.
for the introduction and a warm welcome to everyone joining us today. Well, in my own work coordinating care across more than 75 countries, I have seen firsthand that a provider network is never just a list of names and tariffs. It's the difference between a member getting discharged smoothly versus a family left waiting on a guarantee of payment. Behind every claim, every direct billing transaction, and every quality benchmark, there is a real person hoping the system works when they need it the most. Well, today we'll be looking at what it really takes to build networks that deliver on all fronts: strong quality standards, fair and sustainable tariffs, seamless direct billing, and above all, a member experience that feels effortless. Get the network right, and the cost, care, and confidence all fall into place. If you get it wrong, and everything downstream suffers. These are exactly the questions our panel will help us answer today. So, without any further delay, let me introduce the experts who will guide us through it. Our first panelist is Ms. Mihiri Seneviratne, who is the Assistant General Manager, Fairfirst Insurance, Sri Lanka. Let me just quickly tell a brief introduction about Ms. Mihiri. She's a senior insurance professional with 35 years of industry experience, specializing in health underwriting claims, reinsurance, and portfolio strategy. As Assistant General Manager, Health Underwriting at Fairfirst Insurance Sri Lanka, she leads health underwriting and has played a key role in developing the company's global health proposition. Her expertise spans international medical insurance, risk management, product development, reinsurance, and sustainable health portfolio growth. She brings extensive practical experience and strategic insights into the evolving global health insurance landscape. Thank you so much, Ms. Miri, for joining us today. I know you're in the odd time zone, but we really appreciate and thank you once again. We have our second panelist, who is Mr. Zishan Salam. He's a provider network manager, NGI UAE. Mr. Zishan has led the provider network at National General Insurance UAE since 2015, bringing with him over 17 years of industry experience. During this time, he launched a managed care model for insured groups that proved so successful, it's since been replicated across several large accounts. He's also grown NGI's in house provider network into one of the largest in the UAE. Thank you so much, Mr. Zishan, and good to see you. Last but not the least, we have Dr. Geeta Sadana, who is the Director, Medical Claims Audit and Training at Prospera Global. Dr. Geeta comes with more than 23 years of experience in the industry, with spending 14 years in UAE insurance market. She's known for a calm, nurturing personality and her ability to make people feel supported and at ease. She brings clarity and structure to complex medical and insurance conversations. Thank you so much, Dr. Geeta, and pleasure to have you on board again. And over to you, Dr. Geeta. We look forward to a very fruitful and insightful discussion. Thank you.
Thank you. Thank you so much, Ankit, for this warm introduction. It's a pleasure to take this forward and moderate today's session. Our topic, as you all know by now, is building smarter provider networks, which is truly an important area in shaping better healthcare access and outcomes. As Nancy has already mentioned, that a strong provider network is not just about having a wide range of hospitals and healthcare. It's also about ensuring the right balance between quality of care, reasonable tariffs, and yes, most importantly, a positive experience for the member. So, with that context, let's get started with our discussion and explore some of these aspects in greater detail. And let me begin with our first question, which is for Miss Mary. Hi, hello, Mary. How are you?
Hi, doctor. I'm fine. Thank you.
Yeah, all right. So my first question would be like, what do you think? How does the structure and quality of a provider network influences the claims frequency and severity? And if we talk about the underwriting perspective, how does it affect the product pricing? Apart from this, we would also like to know, like, what do you think? How it impacts a long-term sustainability of an insurance portfolio?
All right, doctor. Thank you so much for the question. And thank you, Nancy and the Prospera team for inviting me for this very valuable session. And good morning to all, and thanks for joining for this webinar. So for the question that you may raise, I would like to give a keynote on that, saying a provider network is not just a claims management tool. How I would look at it is an underwriting variable. However, From an insurance perspective, the structure and quality of the provider network can have a direct impact on both claims frequency and the severity, which we all know who are basically in this field. So therefore, I would consider the provider network as an important underwriting variable rather than something that sits on only with claims management. A well-structured network gives the insurer greater visibility and control over tariffs, treatment patterns, utilization, and quality of care. It is also allows us to negotiate appropriate packages and establish benchmarks for different procedures. But the quality of the network is equally important. As doctor said, if you focus only on member of providers or the discount negotiated, we may actually increase the overall claims cost. So if I may say about the provider behavior, treatment patterns, length of stay, the diagnosis, readmissions, and clinical outcomes can have a much greater impact on the ultimate cost. This is actually information should therefore feed back into the underwriting and pricing. So this is something core when we are basically pricing a health product. If an insurer sees persistent increases in utilization, severity, or treatment cost within a particular network, that experience needs to be reflected in assumptions around medical inflation, claims frequency, and expected severity, and ultimately the premium adequacy. So these are key major factors that we always need to pricing health, irrespective of whether it's corporate or individual. So in my view, the long-term objective is not simply to build a large provider network. It is to build a high-quality, data-driven network that produces predictable claims outcome and sustainable healthcare cost while maintaining good access for members. The provider network should ultimately become part of an insurer's risk management architecture, not operate as a separate claims function. I think I answered your question.
Thank you. Thank you so much, Meeri. And it was really insightful. Actually, it is giving a new direction, that definitely the network is not just the claims as what we really think, that network and claims, they go hand in hand. But you have added such a good thing that it is not just the claims, it should be apart, it should be considered along with the underwriting as well, because a lot depends upon how you sell the policy, how you then have the premiums and everything for an individual policyholder or for a group or for a corporate. Okay, now I'll bring Zishan into conversation. Okay, so as you know, what we have already said that when we think that more extensive the network, it becomes, it's a USP for a client for us to have it on board. And the clients, no doubt, are attracted towards the size of the network. But what do you think if a network had to be defended on performance rather than the count, which measures would matter most across clinical quality, accessibility, tariff competitiveness, and member experience? Which indicators you think are most effective in distinguishing generally high-performing providers from those that simply generate higher volumes?
Thank you, Dr. Geeta, and hello, everyone. The whole journey for the member, I think, matters ideally over here because they are the policyholders. You have to have, we're in the service industry, so they have to have a seamless kind of journey throughout. Every time there's a hiccup over there, it's the provider to blame, it's the payer to blame, it's the insurance company to blame, but the member doesn't really know what's happening. So that, I think, is a key indicator that the member's journey has to be seamless. Yes, clinical quality, accessibility, everything matters. How you're portraying your portal to the provider matters. Ease of access, everything has to be in line with the providers. You have to keep on educating them because these providers, I mean, the larger providers have a lot of turnaround. They have people joining, leaving at every moment. So there are new people joining. So definitely regular education to the providers matters. Tariff, yes. I mean, tariff matters the most, I would say, for an insurer, because this is in line with what our underwriters are pricing. So if there is any change in tariffs, we have to keep the claims and underwriters, everyone in line, because this could mean that there could be changes in the premiums that we're offering. So everything pretty much has to be balanced. Yes, member experience, I would say, is number one. Your geographic locations of these providers, having a lot of providers is good, but can be overutilized as well. But you have to give the members access in every geographic location, which is where their kind of experience is enhanced.
This is really interesting, Zishan, and I think many of the audience can definitely relate to it. And now, coming to the next question, this is for Miri. Miri, provider, as what we're discussing about the discount now, yes, a provider can definitely give a very good, very attractive discount. But when we analyze the data, we often see, that the per claim cost is still high, even though the discount was superb. So, what should insurers assess beyond the headline discount to determine whether a provider is genuinely cost effective? Like, which signals you think are the most revealing a pattern of a provider? Is it utilization, as a coding behavior, or the repeat visits when they call the member for follow visits, let's say after every 3 days or after a week, or a readmission, or the clinical outcomes? So, we would like to have your feedback on this so that we understand, what is more important when we say that this is a good provider and yes, this should be taken into an account.
Okay, thanks, Doctor. So when it comes to discount, I would say a discount is not a saving unless it reduces the total cost of care. I think one of the biggest mistakes that the insurers can make is to look at the headline discount in isolation. A 20 or 30% discount sounds very attractive, but what matters is the final cost of the episode of care and ultimately the claim cost per member. I would therefore look beyond the tariff and assess the provider's utilization pattern, case mix, the average cost per episode, length of stay, the diagnostic intensity, the repeat visits, readmissions, referral patterns, and treatment outcomes. Coding behavior is also important. If there is a consistent pattern of upcoding, higher severity coding, or unnecessary investigations, the headline discount can become misleading. And I would also compare providers on a like-for-like basis. If you take a hospital treating a more complex case, mix may naturally have a higher average claim. So we need to distinguish between the clinical complexity from avoidable utilization, which I think is quite important. Ultimately, I would look at a total cost of care, not negotiated discounts. The real question should be, after taking into the utilization, the severity, treatment pathways, and outcomes. So it's provider delivering better value for the insurer member. And I would add for further dimensions like quality of outcomes. So the cheapest provider is not necessarily the most cost-effective provider if poor outcomes result in repeat treatment, complications, or readmissions. So this is actually, I would say, a very sensitive area when it comes to the discounts that we are talking about. So it's the discount, the utilization, the case mix, outcome, and the total cost.
Okay. Okay, thanks, Miri. And this is for both of you, for Miri and Zishan. Let us say if you find that a provider, basically where we have got a very good discount, but the average cost for the similar case mix is more. So what are the steps, that we should take? Like how we can talk to them, or should we remove it from panel, or should we speak to them, or how to manage the cost over there? So yes, first we'd like to listen from you, Zishan, and then could be from Miri.
We shouldn't remove them from the network because you have members going there. Obviously, if it's a highly utilized provider, that would disrupt a lot of services, and then complaints can reach a level where sometimes a policy might get cancelled, because we do have preferred providers everywhere. And if it is one of those preferred providers, then no, removing them is not going to help. Uh, yes, I mean, fraud and abuse everywhere. We do face that with a lot of providers. But provider education, I think you have, I mean, apart from the network, you have your auditors, your medical auditors in every company. They should be looking into everything, educating the providers along with the network on where they're going wrong, where we see leakage, where we see room for improvement. So all these things have to be considered. Maybe then, if the provider isn't getting on the right track, then you can suspend the provider for a while, maybe just as a slap on the back of your hand. But I think all these measures have to go in line with, again, member satisfaction.
All right. Thanks, Sushant. And yes, Miri, we would like to hear from you.
Yeah, so if I may address on the concerns that you raised on the provider behavior, on the abusing, the overcharging, and that kind of situation. I would say maybe country to country the procedures are different. But then again, as Ishan rightly said, by discontinuing or blacklisting them from our provider network is not going to serve us, because our clients may go for any emergencies there. So I think it's a fact that we need to address with the hospitals. And also, I would say maybe we should stop direct billing with them, and maybe we should give them some sort of like a kind of alert on this is the action that we would be taking, unless otherwise they are not going to take any action on the procedures that they are basically practicing on, I would say, the bad practices, unless they correct it.
Thank you. Thank you so much, Miri and Zishan, both of you, because I know this is one of the hot topics while we are doing the analysis and while we are auditing the claims. So thank you so much for the insight. Okay, now my next question is for you, Zishan. Direct billing is central to a seamless member journey, but it can definitely increase utilization, which we have been discussing, the claims leakage and operational complexity. So how do you think can insurers strengthen the controls without creating unnecessary delays or frictions for the members and providers?
Again, over here, provider education is very important. Everything that you are showing to the provider for the member has to be clear cut. We have to understand that the providers as well are busy. They don't have your only patient over there, they have 10 other insurers waiting behind them. Everyone's in a rush to see the doctor, everyone's in a rush. So we have to give, or understand rather, the provider's side of this as well. You have to have your workflow integration, your validation rules, your adjudication rules in place. DHA, I mean, in this part of the world, Dubai Health Authority does have adjudication tools. However, you have insurance companies building their own. In NGI, we recently have built our claims guard, what we call it. So this is kind of a real-time adjudication. This lessens the waiting time. Your pre-authorizations are much more streamlined. A lot of them are auto-approved, if you will, certain procedures. So basically, automating these things does help a provider, does help the member, and eventually we get less complaints. Yes, utilization is an issue. This is something you have to keep looking at, whether it's through pre-authorization, whether it's through audit, post-op claims. I guess these data filters, if you might call it, is what you need for the seamless journey.
Thank you. Thank you so much, Zishan. It's absolutely correct that, of course, we have to have the measures at the level of pre-authorization and, of course, at the level of system for the automatic validation. Yes, that is how it should be. Thank you so much for that. Okay, now, Miri, I would like to ask this question from you now. Like, how can insurance design direct billing and claim controls that contain avoidable cost while ensuring that genuine cases are authorized and settled quickly, so that the genuine thing doesn't have to wait? We do that promptly, and of course with clear communication for both members and the providers. Mary, you are on mute.
I'm extremely sorry about it.
It's fine. That's fine.
Okay, so this is where you should bring in the member experience into the whole picture. The danger is that insurers can create so many controls that members feel the insurer is creating barriers to treatment, which is not the case, right? So we need to understand that why we are bringing these controls should be intelligent, it should be risk-based and largely invisible to the genuine member. So I think the key is to distinguish between the controlling avoidable cost and creating barriers to legitimate treatment. A good direct billing model should achieve both. So the first principle I would say should be risk-based controls rather than applying the same level of scrutiny to every case. Routine, low risk, and clinically straightforward cases should be authorized quickly, which is the case and which should be the norm with every insurer, I would say. While high value, unusual, or potentially inappropriate cases can receive enhanced review. So pre-authorization is important, particularly for high-cost procedures, but it should be supported by clear clinical protocols, defined turnaround times, and escalation mechanisms. So providers should know exactly what information is required, and members should not be left waiting with an explanation. So this is where the insurers should act responsibly, making the patient kind of understanding as to why the billing has gone delayed. And the technology can also play an important role through automated eligibility checks like digital pre-authorization, rules-based claims, validation, and identification for unusual utilization patterns. But control should not stop at the point of authorization. We need to analyze claims afterwards to identify patterns, such as repeat admissions, the unusual coding, the excessive diagnostics or provider-specific utilization, and feed those insights back into the provider negotiations and underwriting. So ultimately, the best direct billing system is one where the member experience speed and simplicity, while the insurer has appropriate controls operating behind the scenes. So I would like to kind of finish it saying the member should experience the process as seamless. The control should largely sit behind the experience rather than become the experience.
Yeah,
Absolutely.
yes. It's absolutely. This is how it should be, Mary. Because of course, member is the one who should be facing a seamless process, and definitely the insurance company cannot just close the eyes because you're very right. If you automate the approvals, like mainly the outpatient approvals, the frequency is too high. If there is no check, is there no audit, then definitely it's going to larger loss ratios, and of course the portfolio is going to bleed. So yes, we have to keep both hand in hand, the seamless experience, and of course our auditors and our systems to be automated with so many rule engines so that we don't overpay or we don't pay for the waste and abuse. Thank you so much for that. Okay, Zishan, now coming over to you. How can claims data, because we're discussing about the claims data now, so that we can have a control on the fraud, waste, and abuse. So, how do you think a claims data, provider performance indicators, and member feedback be brought together to continuously optimize the network, include the provider tiering, corrective actions, and the development of preferred pathways or centers of excellence? And we would love to hear some practical examples from you to understand this in a better way.
Uh, I'll start off with the center of excellence. Actually, in this part of the world, in UAE, you have two kinds. You have the center of excellence providers that are kind of identified by the government, which is the Dubai Health Authority, the authorities over here. And then you have the Center of Excellence, which every insurance company kind of has their own. You've got probably separate ones for orthopedics, separate ones for mother and child. So every insurance company has identified their own center of excellence, and this is what they utilized for that particular field. Data, bringing it together, I think, okay, your first part was the volume of providers over here. We have in excess of 5,000 providers in UAE and growing. So the volume is just massive, but your utilization is always restricted to those few big groups, I would say. You've got a handful of groups which have multiple providers. Now, bringing their data together is key over here because your members, this is where your members are actually going. You can have corrective action plans for these providers, but realistically speaking, in this part of the world, providers are very powerful. It's more of a relationship you would want to go for as opposed to a punishment. So you do bring the data together, but you discuss it with the providers. This has to be a mutual kind of arrangement, a mutual understanding. At the end of the day, they're here as a business as well, apart from healthcare. We're over here ensuring our lives, ensuring the members. So everything has to be built into a relationship, which is where you can consider corrective action plans, discussing it with the providers. Your clinical audits and everything, yes, they do matter, but at the end of the day, relationship does matter. I think Dr. Geeta is well aware of the relationship and the requirements in this part of the world. So I think this is it. Center of excellence, we do have center of excellence providers which are set by the government, but they are obviously, because they're center of excellence, they are extremely expensive. To give you an example, we do have center of excellence in Abu Dhabi, which on a factor of 1 to 3, we have them at factor 3, which is the high, but even then their costs are not covered. So to understand from the provider's perspective, the government is actually for everything that we are not paying. So even though we think we're paying high, but they're still getting subsidized by the government because, I mean, the cost for them is high. So it is important to kind of marry everything together. Have your own, I mean, you've got the authorities telling you the center of excellence, but have your own set of providers as well, where you know who to send where, kind of thing.
Thank you. Thanks, Ishan. And we would like to hear something for the same question from you to Miri, because we want to understand how Sri Lanka is working. So what do you think? How can claims data and provider performance indicators and member feedback, if all brought together, how can we use that to optimize the network? Because I'm sure even you would be sometimes expanding or deleting the networks or adding something or changing the tiering of the network. So we would like to understand from you now how it's being managed in Sri Lanka.
Yeah, thanks. So, Doctor, how we manage in Sri Lanka is a bit different to maybe other countries. So, as I mentioned previously, so wherever that we get the member data, the claims data and all that, and if we see like, you know, there are a lot of abusing happening through certain consultants and maybe the providers. So we basically carry out investigations and we go ahead and delist them from our provider network, because we have to take that action, because there are certain providers, I would say, very much basically deteriorate, I would say, into that market sort of. So we come across largely into certain areas. I would say it's not the western part of it, maybe the interior part of our country. So we always ensure that every claim is sort of, you know, very well reviewed, and we don't want any sort of, you know, bad information or other bad name carries over just to say that whoever who abuses any claim could be settled at fair first. So we always do a legitimate processing of any claim, and data actually helps us to sort of, you know, go in front of a corporate and basically discuss as to how we should zero it or rather control it. So that's how we basically take action on those areas. I hope I answered.
Yes. Thank you,
the
Viri.
question.
And do you also have different tiers of network in Sri Lanka, as we do have, we have got different tiers in Dubai, in UAE. So do we have something similar in Sri Lanka as well?
We only have the private and the government. So within the
Okay.
private, we don't have like different tiers. So it's basically, if you take the Western province has the major private hospitals, the providers. The rest of, I mean, other areas also, the main cities, we do have the private, but then the other sector is the government sector. So for the government, there is no cost being kind of an allocated. So basically, there's no cost involved in the any sort of treatment from any patient.
Okay, all right.
So we always do a cash grant under our policy to them.
All right. And okay, Zishan, because you are there for a very long time, just wanted to know if this kind of data analysis, has it helped you, or you have thought about changing that tier of a particular provider? If you find someone is abusive, so definitely you cannot delist. But have you changed that tier so that it is utilized lesser?
Again, provider education over here is important. So when we do analyze something, if we see the cost per encounter, or not just the cost per encounter, even the utilization, I mean, the cost per encounter could be managed at a certain threshold, which is acceptable to you.
Okay.
But at the same time, if in 1 month they have, let's say, 100 consultation as opposed to every other month where they had 15 or 20, it does raise alarms. Again, delisting a provider is something which we would do as a last step. In cases of fraud, that would be the first step, but in all other cases, that would be the last step. So delisting a provider would not be, at least in this part of the world, accepted by the members.
Yeah.
But yes, if we still see abuse, or if we still see the cost per encounter going significantly higher, the utilization intentionally being increased, then we move them to a higher network where they have lower volume. So the higher that they are, they have a lower volume. But if they're in all my networks, in all the tiers of network, some insurance companies can have 3 tiers, some can have 6. We have 7. I know insurance companies in UAE which have 12, 13 tiers. So playing with the tiers is key. I think moving them up or down using all this data would help. And this is how we at least try to control the utilization and the cost over here.
Yeah. So it means that tiering is really, really important and really helpful. Right. Yeah. Indirectly in controlling the cost and even the fraud. And I shouldn't say fraud, the waste and abuse, I would say. Because fraud is a very, very harsh term to use,
Fraud is the harsh term, but there is a lot of wastage, I would say.
Yes.
And just by controlling that wastage, we have seen, and you're very well aware of that, that just by controlling the abuse and the wastage, we have seen loss ratios go down by 30 to 40%.
Yes, right, yeah.
Just by controlling that.
Yes, right, yeah. So yes, thank you so much, both of you, for this insightful session. And yes, I think the audience definitely can relate to this, that network does play a major role in controlling the cost and, of course, in maintaining the loss ratios, which are very, very important for the renewal of any kind of corporate or any client. So thank you so much, both of you. And I'm sure the audience would be having so many questions now, because mine definitely were not that much. So over to you, Ankit, now for the question and answer session.
Thank you, Dr. Geeta, and thank you, Mr. Zishan and Ms. Mihiri. Yes, so in the beginning, we mentioned that audience are free to put up their questions in the chat window. I can already see that we have few. I would just quickly take a few of the questions, and probably I can direct it to probably Mr. Zishan and Ms. Mihiri as well. So let me just quickly read first question. Okay, I'll take this one. What do you do when your best provider is also your most expensive one? How do you reward good care without overspending? So yeah, many times it happens that the quality and the level of treatment given by a hospital is also comes with an expensive cost. So how do you take care of that? How do you balance between that? So probably Zishan, probably you would like to take on this question.
I think the easiest way to put this would be you get what you paid for over here. So yes, the good quality providers do come at a cost.
Yeah.
We all know this. I think this is standard in every country. Every country has different markets, but this is standard in every country. The better the outcomes, the I think the more leverage they have to increase their cost. And again, I'm not taking anyone's side over here, but this is the way it is. And in UAE as well, you have your big players like your Mediclinic, your King's College, Saudi German. These are high outcome, I mean, good quality outcome providers, and they are pretty expensive compared to the rest of the market. But you have them in your highest tiers, so your volume is controlled over there. But that doesn't mean that you're not going to send your lower tiered members into these hospitals. So if need be, we do have cases where, on a case by case, if needed, we do send them, even though they're not in the network. It will come to us at a much higher cost, but we know the outcome is going to be much better than sending them to a provider that might cost me one third. So,
Right.
again, insurance companies do have to take this decision sometimes.
Right, right. Very well said. Okay, moving on to the second one.
Ankit, just I
Yes,
want
yes,
to
Ms. Mimi.
disturb
Sorry,
you.
yeah.
I have a question for Dishan. I just want to check with you. You said your provider networks are tiered. So basically, the way the product has been sort of laid out is also the provider network, the tiered basis has been incorporated into underwriting. Am I right? So there will be a
Yes,
couple of schemes that certain people go into certain tiers, the rest of can go into different tiers.
yes, very
Is
right.
that the
So
way the
we have
policy has been structured? Or?
very much so. So in UAE, every policy is structured like that. NGI was actually one of the last one to tier their networks. We tiered our networks, I think, somewhere in 2016. I think Dr. Geeta would remember better. But NGI, before that, we had a completely open network. After that, the underwriting, the pricing, everything was so much more streamlined because we know where the high cost providers are. We know that if it's high cost, you have to pay a higher premium. So a lower cost product, as you would say, or a basic product would have a lot less providers, but those providers cost-wise would be much more feasible to me. So premium does play a role over there, and premiums are much more streamlined with different tiers of network.
Understood. Thanks, Zishan.
I would like to add something over here, Mary. See, you'll be surprised why he's saying Dr. Geeta would know it because my background is I was in UAE. I was there with NGI only, where we both were together. You can say for around 14 years. So could be that's the reason he's saying, Dr. Geeta would be knowing about it. And yes, to add on that, like a single policy, the tiers as what he's mentioning, it is depending upon the categories. Like of course, if you want to have like a particular client or corporate is there, and of course they have got different categories. The management is there, the managers are there, then of course the employees, the lower ones are there. So for a single product, for a single policy as well, a different tiers of networks are given. Because in that case, you can keep everyone pleased, everyone is happy, the VIPs can go to your best tier, which has got the entire, whatever the network you
Right.
have. And then as you grow further, you can remove the more expensive ones or the ones which you think they have got more of utilization or something like that. So that really helps in controlling the cost and giving a very competitive rate to your clients. It really helps in getting the business. Yeah.
Good point. Thanks,
Yeah.
Doctor.
Thank
Thank
you.
you.
Yeah.
Thank you, Dr. Geeta. Yeah. Okay, so we have another question. I'll take it up, which says that contracts and what's actually loaded in the system often don't match. How often should team check for these mismatches before they cause billing disputes? I think it is more on an operational front. Somebody's asking that contracts which are actually loaded in the system and in reality they don't match. So how do you check that? How often do you audit that? Uh, Probably both of you, any one of you would like to take this question up.
Sure. I mean, contracts are in this part of the world again are set. We have a standard provider contract for Abu Dhabi. We have a standard provider contract for Dubai and Northern Emirates. So we don't have to make. So the best part over here is that it's already set by the authorities. Likewise, you have to set it in the system. So there's no change over there. So every provider, whether it's from Abu Dhabi or Dubai and Northern Emirates, would have pretty much the same rules, regulations that they have to follow, like us.
Yeah.
So for us, I don't think we have that issue at all because everything's pretty much set in the system by our IT, by our production, by our writers, and eventually it trickles down to your network. So everything has to match. A mismatch is highly unlikely, I would say.
All right. Okay. Perfect. Mihri, would you like to share your thoughts in your
Well, I
processes,
would
probably?
I agree with Zisha. So it's basically very straightforward, as you well said. So it'll be set it up in the system and everything is in, and there's no more changes to be done in between or anything.
All right. Great. Perfect. Okay. Another one who's asking is, for a member, a good network just means getting the right care without hassle. What is one small change that improved member trust the most for you? Okay, I'll just read out again. For a member, a good network just means getting the right care without hassle. What is one small change that improved member trust the most for you? It is more of a customer experience, customer service perspective, probably. Okay,
I would
yeah.
say the way you have been handling the direct billing for that particular customer without any hassle, because sometimes you may tend to go into reviewing the bill, and sometimes the discharge may take long due to certain things. I would say the overcharges done by the consultants or maybe the hospital. So the little thing would be, I would say, we will be proactively informing the client that this is what it is, and without a further delay, we will handle it with the hospital without kind of escalating that delay onto the patient at the discharge.
All right. All right.
Is that the answer? I hope I don't.
Yeah. Right. Okay, there is one interesting one which says many companies have messy provider and claims data. What is the minimum you need to clean up before probably an AI tool can actually be useful? I'm not really sure how much are you integrating AI into your current processes when it comes to networking or probably managing the claims data. But have you ever thought about it, or is something happening? Probably, at in Sri
Not,
Lanka, probably, or Zishan, probably you can answer.
Yeah,
not
Yeah.
at the moment.
we have.
Sorry,
Sure,
you go
Mary,
ahead.
go ahead. No, please go ahead.
Yes, Miss Mihiri. Yeah.
We are not
Yeah.
not at the moment, but we'll be looking at it into the near future.
Okay. Okay.
For us, we are actually currently looking at it. We have our IT team that has just taken an approval from the board to develop something. It will have your claims, your network, part of the underwriting, part of the production built into it. It is a long process. It's not something that is can be built overnight. It is a long, lengthy, and expensive process. So we do have the approvals for it, but we've just about started work on it. I don't think at the moment anyone in this market is proactively using that completely. But I do see the change coming. At the same time, yes, AI is helpful, but yes, you do need human intervention in all these aspects.
Of course, yes. And AI being the hot, topic these days, and eventually getting into every industry and every sort of processes. I think eventually it'll make it to, the claims and networking as well. Okay, I think we are almost close to the time, but I'll just take one more question. That'll be the last one. It says, how can we verify the surgery charges and surgeon charges are justified if the hospital is not within the network? Okay, good one. So we are talking about non-network hospitals now. If you are covering, or if you are, covering the treatment at a non-network for a patient, how will you verify that surgeon charges are, or surgery charges are up to the mark, or match the tariff, or match the usual standards? Probably that's the listener wants to ask.
Okay, let me answer that question. Well, in the Sri Lankan context, unfortunately, we don't have a tariff for the consultation, and for certain surgeries, we do have like packages that have been stipulated by certain providers. So in that case, only what we could do is when what we could see is in a particular bill, maybe with the experience that the particular consultant, how much he charged for a particular surgery, a similar surgery, and maybe then look at it as whether they have charged appropriately. And it doesn't have to be whether it's a provider or non-provider. So it's basically, I would say the issue is there on both segments.
All right. Okay. Yeah. Zishan, would you like to share some thoughts?
Likewise here as well. Everything is packaged. Majority of the country is running on packaged prices for surgeries. Even if it's let's say not in the network and we're sending a member over there, everything is predefined before the member actually reaches the hospital. So it's set in a very easy way in UAE where you have factors and you're negotiating just on the factor. Everything else is set by the authorities over here. The weightage, we call it DRG over here. So the DRGs are completely set by the authorities. All you're then negotiating on is the factor. The member usually doesn't have to know or should be, I think, bothered with the prices or anything about that. Because this is completely, if we are moving the member to a non-network provider, then we are covering the cost. So as an insurance company, we would definitely negotiate on the best rates possible, even if it's slightly higher than an in-network provider, but maybe the specialties or the you can say expertise over there are much advanced than anywhere else.
Right. Well said, Zishan. I totally agree. And at this point, we can have AI into place wherein you can do all the research of the current location and probably the kind of network the provider belongs to, and then probably we can get an answer. Yeah, maybe. All right. So that brings to an end of a very insightful session today. I would really like to extend my heartfelt thank you to the wonderful panelists, Ms. Mihiri, Zishan, and Dr. Gita, of course, for sharing their time, insights, and experience. Your perspectives have given us all the great deal to reflect on as we think about building smarter, stronger provider networks. Thank you to our audience for joining us and for your thoughtful questions. And a big thank you to the entire team behind this session. None of this happens without the IT support. We'll be sharing a feedback link shortly. We would love to hear your thoughts. So each one of you will receive a feedback link where you can put in your questions or put in your thoughts, and we'll address it to the right team. You'll also receive the YouTube link soon so that you can watch the webinar again if you have any concerns and share it with your friends and colleagues. We'll be back with another engaging webinar soon. Until then, stay tuned. But I would just like to have a moment here and probably ask a panelist to give one final thought on the entire session, probably, or the topic, or anything you would like to discuss. So we'll start with Ms. Mihiri. Yeah.
Okay, thanks, Ankit, and thanks, Prospera Health, for inviting me for this webinar. So I would end the session with a small note saying, from an insurer's perspective, a smarter provider network is not necessarily the network with the largest number of hospitals or providers. So as I always say, it is one where quality, cost, clinical outcomes, and the member experience are brought together. So we need to ensure that members have access to appropriate quality care, providers are remunerated fairly, tariffs remain sustainable, and the insurer can manage the portfolio responsibly over the long term. Ultimately, the member should experience the network seamless, reassuring, while the insurer sees its sustainable and well-governed ecosystem. Thank you so much.
Thank you, Ms. Mary. Well said. Yes, Mr. Zishan? Yeah, over to you.
I'd like to thank everyone. Well, I think the exit note would be that, yes, tariffs, like Mihiri said, that are important. Having a large network, having pretty much each and every provider in your network is not key over here. I think the quality matters a lot. Your tariffs have evolved so much in the last decade or so, I would say, because I guess information is readily available. You are more, as an insurer, aware of the cost, where, for example, vitamin D, you knew everyone was charging 500 dirhams before. But eventually you found out that the cost of vitamin D is 36 dirhams. And that is where the evolution came in, where you as an insurer are now aware of the cost. Yes, you're going to add a profit margin for, let's say, a clinic or a hospital or a diagnostic center for that matter, and take it from there. So I think the tariffs now are much more in line with the cost and the quality as they were before. So I think we are going in the right direction, hopefully before AI takes over. And so, yes, I guess that's about it. Thank you very much.
Thank you, Mr. Zishan. And Dr. Geeta, Nancy, anything else you would like to add?
Thank you
Or
so
before we
much.
go?
I
Yeah.
think this was very, very insightful session, and definitely we look forward to having such more sessions, again. Over to you, Dr. Geeta.
Yeah, it was really, I'm really happy to have
Yeah,
you two both over here today. It was really insightful, very nice, and a very
yeah,
interesting session, I would say. And
absolutely,
of course,
absolutely.
yes, it was quite interesting. And especially when Zishan has taken an example of vitamin D, this takes me back to that era. So yes, it's really helpful when you analyze the data. That is the key actually, because just
Absolutely.
giving approvals and looking at those things doesn't help. It is ultimately like when you analyze it, it's either it's human or it is AI, but someone has to analyze the data. But definitely, even if AI has done it, a person, a human figure has to again go through it and to understand what
Yeah.
necessary steps have to be taken. Because these two things, yes, have to go hand in hand. And yes, agree with both of you. Thank you.
True.
Thank you for today's insightful
Absolutely.
session. Yeah.
Yeah. And just to add what Dr. Geeta said, somebody has to monitor the AI as well. And that's what we are here for. So yeah, we will end on that note. Thank you so much, everybody, and have a great weekend.
Thank
We
you.
hope to catch up soon. Yeah. Thank you.
And
Thanks,
thank you
Andy.
so
Thanks,
much.
team.
Thank
Thanks.
you
Bye.
so
Thank you.
much.
Bye.
Bye.